our next presentation. So we're starting with the methodology theme, MIDAS, then IMPaCT, who we've heard from, and then Care and Health Informatics. So if our panel can come up to the stage, and we're starting with presentations online. Jerry is one of our public advisors, which is a nice flow from the last session.
Yes.
Thank you. Welcome, Jerry.
Thank you, Mark, and good morning, everybody. For critical care interventions. End-of-life care is a key aspect of her role. Abigail is a qualified nurse as of 2012 and has maintained an interest in continued professional development and delivering evidence-based care. She holds an MSc in nursing, PG certificate in enhanced care, and is qualified as an advanced clinical practitioner from 2020. Abigail is one of our ARC Northwest Races interns working with the MIDAS team, and she's going to talk about her experience of being an ARC Northwest intern about her Races project. The title of Abigail's presentation is Lower Socioeconomic Position Associated with Poorer Outcomes for End-of-Life Care. Following Abigail, we will have, I think, a minor change to our ordered programme. One of our second speakers, we believe, is unwell and may not be here, but we will hear from one of our other public advisors, Peter Lloyd. Peter will be attending remotely. Peter is a public advisor and co-theme lead for CHAI. Peter himself is a retired academic and policy consultant and retired as a professor of urban geography in 2021. Peter is going to provide a public advisor's guide to CHAI, which is the Care and Health Informatics theme. And finally today, we'll hear from the last of our speakers, Andrew Riley from the IMPaCT theme. And Andrew's is a pre-recorded presentation. Andrew is an ARC Northwest funded PhD student in health services research based in the University of Liverpool. Working with NHS community healthcare providers, his research project is a process evaluation of a novel community health worker programme being implemented in 3 pilot areas in England. This year, Andrew was awarded a grant from the NIHR through the local authority Shore Placement Award for research collaborations. Thankfully, that is shortened to LA Spark, which certainly helps me. This placement involves working with Warrington MBC's public health team to identify research opportunities within the local authority. Andrew's presentation will summarise his work so far in investigating opportunities to developing and sustaining collaborative practices between local government and academia. So I'd now like to invite our first speaker, Abigail, to come to the lectern.
Hi everyone. So as I've been introduced, I'm just going to have a chat to you today about my Races internship, where I've asked the question, is lower socioeconomic position associated with poorer outcomes in end-of-life care? As you know, I'm an advanced clinical practitioner at East Lancashire Hospital Trust, and so quite a lot of my role is actually to do with end-of-life care. Could I have the next slide? So, my area of interest and why I chose it. My job role, I work as part of a critical care outreach team. So I see patients who are deteriorating out and about within the hospital, so either on the wards or in the emergency department. And that's with a view to either expediting them to get to critical care quickly or to hopefully stop that from having to happen with early intervention so that they actually improve in that ward area. So within my role, I do see missed opportunities for what could have been done differently. And it's often at a point where we can't really change the trajectory. Within my trust, we take part in the National Care of the Dying audit every year, and unfortunately the results have just come out prior to my Races application, and we hadn't done that great in the 2019 audit, particularly in areas of communication and talking to patients about preferred place of death, for example. And then I think nationally there are reports such as One Chance to Get It Right, which is saying that there are areas for improvement within our end-of-life care that we provide. So I think it's something that needs a little bit more attention, particularly on the shop floor, as it were, and seeing if there are interventions that we can improve on. So next slide, please. So my article choice, after a really good search, I found this wonderful article, which is Socioeconomic Position and Use of Healthcare in the Last Year of Life, a Systematic Review and Meta-Analysis, which was perfect for what I was actually looking for. So the next slide. So the review authors, they screened a huge amount of articles, nearly 15,000 articles for inclusion. 209 were included in the review and 112 medium and high quality studies included in the meta-analysis. They were from high-income countries, articles predominantly from the United States and Europe, including the UK and Canada. There are a few from Australia and Korea as well, but most of these. Deprivation categorised mostly by one or two factors, area and education being the most common, but also income, insurance, occupation and or housing. A few of them use them all, but mostly just one or two. Next slide. Thank you. Key findings, quite stark really, that individuals living in the most deprived areas were more likely to access acute hospital services in the last 3 months of their life, and they were more likely to die in hospital. They were also less likely to receive specialist palliative care, and that was also found with individuals with lower levels of education as well. Yeah, next slide, please. So then my part really, the racist commentary. So we did a critical appraisal of the review using Joanna Briggs, and found that it was an accurate and comprehensive review of the evidence. I think 11 of the 12 parameters were met, so found it to be a good review. We also found that it aligned with other research in the field, correlating that socioeconomic position can determine how, when and why people die. And importantly, the patient experience is adversely affected by these things, with people from lower socioeconomic positions being found to be more passive, more accepting of, well, that's what I've been told and that's what the doctor says, and more likely to rely on relatives with higher levels of education. And I think we need to put that in the context of having been through COVID, where we've stopped all visiting, we're only just restarting that. So these disparities are even further now, that people haven't been there to advocate for the relatives. Add that to often language barriers, and the inequalities have become bigger, or I've seen them as that within my practice. So next slide, please. So goals of implementation. I'm just starting the implementation journey really, so just a few small goals. Trying to reduce inequality, widen access, enhance communication with patients and improve the patient experience overall of that end-of-life care. Next slide. So a brief plan that I'm just working on at the moment. I think we have all the tools that we need. We just need to bring them together. Within my role, as I say, we see patients who are really unwell and approaching the end of life. So we've got that patient population who are accessing the acute services more frequently at the end of life. We've also got a great palliative care service within the hospital. And it's just potentially about marrying these people up. So the specialist palliative care service and the people who are at the end of life, potentially by involving the MDT a little bit more and empowering people to make referrals into the services. And hopefully to improve that end of life care and advanced care planning a little bit earlier so that we can really listen and make it more patient focused. Next slide, please. So that is the end of my presentation. I just wanted to acknowledge Jo Harrison in particular for all the support that she's given me, as I think I would still be stuck on the introduction if it wasn't for her. And to the ARC, of course, for giving me this opportunity.
Thank you very much, Zoya. As stated, we unfortunately won't have one of our next speakers with us, Pete Dixon. Unfortunately, Pete's not been able to attend with us in person today. But is Pete here? Yeah?
I'm online. Yeah, I am able to do this.
Apologies. Thank you very much. So we have two people attending remotely now for our next session, which is our colleagues Pete Dixon and the aforementioned Peter Lloyd. We're going to hear from Pete first.
No, you
do a brief introduction of yourself, please, as well, before we get into your presentation.
Okay. What I wanted to do with this briefly, and I'm going to try to be very brief, is to do the presentation I did for the public advisors a few weeks ago. Because chai, what's chai? It doesn't tell you much in its title. It's Care and Health Informatics. The reason that that's important is that it leads us into something that is very important, which is called big data. And all the while this morning I've been listening, I've had this one word rattling through my head. It's wonderful stuff that I've been hearing. I'm really into it. I'm part of it. And the word that was rattling around my head is, meanwhile, you get it? Meanwhile, things are going on here in the world of big data that we need to know about. So Chai's role sitting in this space, and I could do with the next slide, please, if that would be possible. There we go. I mean, people say, what is Chai? A bunch of nerds sitting in front of computers being clever and statistical. Well, in a sense, it is that. But actually, it sits in a space that is really important to everything that I've heard this morning. It's about data. One of the things I think we're very sort of pick up on in the context in which we work is how important data is, how much of it there is, shed loads of it coming from everywhere, and how vital that can be for future research. We can do things that we never thought possible with big data, but how we need to worry and concern ourselves about who manages that data, who owns the data, who has access to the data, and most critically, in whose interests that process operates. And the reason I'm saying this is because on Friday, something happened that you won't know about. I'm going to come to that in a bit. So what I want to, if I can get on to my next boring slide, go on. There you are. We're up to our armpits in data. Now, this is a long way from what I've been hearing all morning, of which I'm a part and I'm very supportive of. But there is a context to all this, that things are happening in the world in which we do our good stuff, which we need to be aware of, know about, and be part of. And that's the domain in which Chai sits, Care and Health Informatics, right? That's that domain. Doing clever things with data to get results. And the question there is, who does it? What do they do? And in whose interests do they do it? So we've got to be aware of the things that are going on in this. You can see on the right-hand side of the slide some examples of where having more and better data gives you better research in the COVID context. Or a thing that you may or may not have heard of called EMIS. If I was in the room, I'd ask everybody to put their hand up who knows what EMIS is. It's bread and butter to Chai. It's the stuff they work on. But how many people know what EMIS is? The health professionals among you will know exactly what EMIS is. The GP certainly will, because it is the database on which 50% of the GP data in this country is kept, right? 50% of that data. It's personal data, it's all the stuff. When you go to the portal to get into to book an appointment, it's the same organization. It's EMIS. And the thing about EMIS is it sounds like a neutral data thing. Actually, it's an organization that owns data, the process of your data. It was invented by a couple of academics in Leeds many, many years ago. And one of the things I wanted to do with Chai to promote its role in this is to say how valuable it is. And I thought on Friday, well, I don't have to worry about this. I can tell you how the world values health and care and health informatics. On Friday, and it didn't appear in any newspaper in this country, EMIS was sold to a company called, let me see, I'll get my notes properly here, Optum UK. It was sold. So the data that your GP has and all the local data that I've been hearing people using in research was in EMIS, was sold to a company called Optum. Optum is a wholly owned subsidiary of a multinational corporation based in Minnesota called the United Health Group. And interestingly, this does health informatics, and it also does insurance work. Now that may be relevant at some point in the future. So this sale was valued at £1.24 billion. This was the data that 50% of our GPs have, and a lot of the local health systems have bolted into, was sold for £1.24 billion to a company which is worth £123 billion and is the 7th largest company in terms of turnover in the United States. Now, that may seem like a long way away from what we've all been talking about, but it is critical in terms of knowing what's going on in that world of data. So I'm going to leave you with this, that it's the devil's tightrope. Out there in the world of data, the world in which CHI works, and you'll hear something repeat in a minute about what they do. On the other,
we may have lost Peter there, I think. So a round of applause, though, please, for Peter, everybody. Yeah. And Peter, if you can hear us, please stay online because we'll be taking questions in a few moments. We're now going to go on to hear from Pete Dixon. Over to you, Pete.
Cheers. Thanks, Jerry. I'm one of the aforementioned nerds that Peter referred to earlier. Firstly, sorry, I'm not with you today. I was actually cycling to the venue, got as far as Walton Vale, and my back popped quite painfully, and I had to walk 5 miles back home, and I'm now dosed up on painkillers. So please bear with me if I look a bit zonked out. So I'm basically what I'm going to talk about is how data is used. Some of the work the CAR involved with, specifically a project around improving anticholinergic medication prescribing for older people. Next slide, please. So anticholinergics, for those of you who don't know, are a group of drugs which block neurotransmitters. They're used to treat a variety of common conditions: COPD, asthma, dizziness. You can see others up there just as examples. You can imagine that quite a lot of older people suffer from one or more of these conditions, and as a result, around 1 in 5 of older people, by which we mean 65 plus, are prescribed such medications. Like all medications, they have adverse effects, side effects, and those living with frailty are recognised as being particularly sensitive to these. And if you take one or more of medicines with these properties, that increases the risk of the things on the next slide, please. So delirium and falls, which are short-term adverse outcomes, but they can obviously lead to hospitalization. Longer term, we've got dementia, loss of physical function, loss of independence. You can imagine if you do have a series of falls, that your confidence goes, you're less likely to move around, and unfortunately for some, mortality. Next slide, please. So this project aims to develop something called an anticholinergic medication index, or ACME. That's ACME with an I, it's nothing to do with Roadrunner. And supporting resources to potentially to reduce these potentially harmful medications and reduce the risk of those poor outcomes for older people with frailty. It's a Health Data Research UK project, initially in Yorkshire, specifically around Bradford. Some of the care and health informatics team within ARC are involved, and I'll touch on how we're widening this out to the ARC Northwest Coast later. So what the project did was collate a list of medicines from the literature and kept shortlisted to just under 90. And they've used routinely collected anonymized data for patients from 65 plus who prescribed one of these medications. They're followed, if you like, for 12 months. So followed in the electronic data to see if they were admitted to hospital with either delirium and falls. Next slide, please. So just to give you an idea of the data we're talking about, on the left, you can see this data from primary care, covering around about 900,000 appointments, looking at medication, clinical history, etc., from 86 GP practices. On the right, we've got the secondary care data, so hospitals, 3 NHS trusts, almost 400,000 records, inpatients, outpatients, A&E, prescriptions, what happened in theatre, and they've been brought together in one connected data set, so the anonymized individuals can be followed through to see outcomes. Next slide, please. And then what the statisticians do is have produced a model that has accounted for the impact of those anticholinergic medicines on potential risks of falls and delirium, and produced something called the hazard ratio for each medicine. That can also be adjusted based on various attributes of the patient's age, their gender, whether they've got Parkinson's, a history of incontinence, history of falls, cognitive problems, because they also add to the risk for falls and delirium. And essentially, that produces a cumulative hazard ratio to produce the anticholinergic medication index, the ACME. And that essentially allows someone to see the potential risk of hospitalization for delirium and falls and the impact that the medications can have on it. Next slide, please. So you may say, so what? I mean, you know, it's all very clever. It all sounds a little bit academic so far. So the overall aim of the study is to reduce that ACME score by either reducing the doses or switching to a different medication or stopping the medications completely, but where appropriate, where it's clinically appropriate, where it's safe, and importantly, where the patient agrees with that. We wanted them to be involved and empowered in this. So the model has been developed, and we're currently working with selected GPs to understand how they would like to see the information, because as I said, it produces something called a hazard ratio. There's some GPs, I think, attending here, and some of them will probably be having cold sweat and going back to their biostats courses when they were at med school. It's not necessarily the most intuitive thing to understand. So how would they like to see it? Understand which patients to prioritize. Should it be the ones with the highest ACME scores? Should it be the ones above a certain level? And also identify potential barriers when deprescribing to this age group. I can imagine, so my dad's 89, it was his birthday yesterday. If he got a letter out of the blue saying, we'd like to invite you, you're on these medicines, we'd like to invite you to a structured medicine review to maybe stop some of them, he'd have a massive panic and think something's wrong with him. And so how do we communicate with this age group around deprescribing and for an outcome that is a little bit sort of, you know, it's a bit esoteric, it's possibly going to occur in the future, but not necessarily, and produce easily understandable lay summaries. And next slide, please. So as I said, it's originally in Yorkshire. Some of the Northwest Coast CHI team are involved, and we want to validate the model on a different population. There may be something about that population in Bradford that's special or different or unique, lest we forget it is Yorkshire, they could well be different. So what we want to do is validate the model using area or areas within the Northwest Coast, and then integrate the model, what Peter was saying about EMIS and the different GP systems, integrate that model and the results into the GP system. So maybe a GP can sit down, they'll have someone in front of them, and it'll pop up saying they're taking this medicine. Have you done this ACME index? Have a look at their potential risk of falls. We've been talking to GPs to gain their level of interest locally, which is, you'd be pleased to know, very high. Also co-produce potentially with them what the tool looks like. Working with CIPHER, the Combined Intelligence for Public Health Action, who host a lot of the digital health infrastructure in the Cheshire and Merseyside region at the moment, to aid integration within that system, because it's certainly not a trivial thing to do all that. Could I have the next slide, please? So just a summary, it's just really to show that, put a bit of meat on the bones. I'm aware that sort of data and things can seem a little sort of esoteric and out there. What does it mean in practice? So this is an example of how connected data sets are being used to develop a tool to help improve prescribing. One of the benefits of using these big data sets is there's reduced so-called participation bias. Most of the population are included, and we're not burdening them with surveys on healthcare use, going out and asking people, when was the last time you went to the doctor? When was the last time you had a fall? They don't need to remember all that. We can use the data to show that. But importantly, this is routinely collected data. So going forward, the same data is being collected, so it can be monitored as the time period progresses to assess the effect of intervention. So we can see, has the burden of these anticholinergic medications been reduced, and have falls and delirium hospitalizations also gone down? And next slide, please. I'd just like to, this is a slide just to show who's involved. So over on the other side, the Pennines from the University of Leeds and Bradford Royal Infirmary, as well as people over here at University of Liverpool, some of whom are from the CHI team. And the final slide, please. Thank you for listening, and also just our very subtle message there. We do have vacancies for a public advisor and member organisations co-leads. So please email us if you're interested. I was going to say you could see me in the room, but unfortunately, due to circumstances, that hasn't been possible today. But please don't hesitate to get in touch if you're interested or just want to know a little bit more. We'd love to have a chat with you. Thank you very much.
Thanks, Pete. And Peter, if you could, as stated, if you could stay online, please, after the final presentation in a few moments, we will have a chance for some questions from the floor and from colleagues attending remotely. So we'll now move straight on to our pre-recorded final presentation from Andrew Riley about the research partnerships in Warrington.
Hi, I'm Andrew Riley. I'm a PhD student at the University of Liverpool, studying health services research supported through a studentship from the ARC under the theme Health and Care Across the Life course. I'm going to talk today about research partnerships in Warrington and developing collaborative practices between the local authority and academia, which is some work I'm doing through the NIHR Local Authority Short Placement Award for Research Collaboration. I'll start by providing a bit of context about my PhD, then explain about the award and the placement, and what we found so far in exploring the potential for the local authority to become more research active. My research project is entitled A Mixed Methods Comparative Case Study Evaluation of a Community Health Worker Pilot in 3 settings in England. Community Health Worker Pilot in question has been adopted from one used in Brazil, in which lay health workers provide health education, health promotion, well-being and signposting support to people in their homes and the community. What's unique about this model is that it's a universal offer, open to everyone in a specific geography of around 150 households, regardless of expressed demand or need. It's comprehensive in that it's inclusive of all age groups and health conditions, and it's integrated in that the community health workers are embedded in local primary or community health systems, enabling the intelligence they gather to be fed directly back to healthcare providers. The model is being trialled in Warrington in the northwest, Calderdale in West Yorkshire, and Westminster in central London. My research project will describe what's implemented in each locality, describing how the pilots differ from each other in relation to context. I'll also assess the reach and fidelity of each pilot and identify the processes that facilitate or limit delivery. The fact of context and place is very important for the study, in that each pilot has been commissioned by and is being delivered by different kinds of health service. A community healthcare foundation trust in the northwest, a local authority and GP practice in London, and a CCG in collaboration with the third sector mental health charity in Yorkshire. Thinking about the importance of place and context in my research, I was encouraged by the ARC Doctoral Fellow Network to apply for the Local Authority Spark scheme. This is the Short Placement Award for Research Collaboration. It was launched last year to support individuals to move between practice and the NIHR in order to enhance their careers, developing skills, knowledge and expertise at the interface between local authorities and academia. The scheme supports individuals based in local authorities who want to undertake short placements in the NIHR and individuals within the NIHR who want to take short placements in local authorities. In my case, the scheme seemed like a good opportunity to learn more about the wider health and care ecosystem surrounding the community health worker pilot in one of the localities. To apply for the award, I had to identify a placement host in a local authority that would provide supervision and support. I had to put together a bid, fully costed, with outputs and objectives to be completed within the duration of the placement. After speaking to colleagues from each of the community health worker pilot sites, we felt that I was best placed to create a placement with the public health team at Warrington Borough Council. The Director of Public Health was eager to get involved with the project, so we put together a bid in which I would learn about the local authority's work, thereby learning about the context surrounding the community health worker pilot, and also support the authority in identifying ways that it could become more research active. We agreed that I'd work with them 2 days a week over 4 months, working on 2 separate strands. The first of these is contributing to a new population health management pre-frailty intervention, which is just getting off the ground. And this brings together different providers from the borough, including GPs, the NHS, the third sector, and other branches of local government, to proactively identify individuals at risk of frailty and offer them targeted support. The second strand, which is my focus today, is putting together a report that will outline opportunities for the local authority to become more research active and in collaboration with academia and other research bodies. I'm looking at opportunities across 2 directorates, public health and environment and transport. Discussing the project with a colleague in the public health knowledge and intelligence team, we decided that the best approach would be to identify some case studies from other regions that could illustrate what successful collaboration looks like, and to produce a bank of resources and contacts that the authority could use when seeking to instigate research projects. We jokingly concluded that the objective is to inspire and inform, but I think this fits quite well. The case studies can inspire the team and the information they can use when they want to better understand and evaluate the work that they do in the borough. With this in mind, a month into the placement, I've been building up a bank of contacts, speaking to individuals at different organisations and getting a sense of barriers and opportunities. These have been people in other local authorities such as Halton, Cheshire West and Greater Manchester, and others in organisations such as Liverpool Health Partners, CHAMPS and Bristol Health Partners, which are collaboratives and partnerships with a focus on bridging the gap between research and practice. One of the most fruitful areas has been within the NIHR itself, which has a number of arms and initiatives designed to promote research and collaboration, particularly in relation to local authorities. My understanding is that this drive to promote and support research in local authorities is an acknowledgement of the fact that many local authorities would like to conduct more research and are aware of the valuable resources, insight and intelligence that the localities possess, but they often lack the time, resources and expertise to conduct long, involved research projects. Some interesting research that looked at these barriers was undertaken by the NIHR Public Health Research in 2020. They set up a program to explore how systems could be developed at a local level to support sustainable research in local authorities. Findings were synthesized by Dr. Dear Coop from Lancaster University, who has a research practitioner role with the NIHR, looking at how the program's findings can be implemented in the Northwest. I won't go into detail about the findings, but these can be found online or by contacting Dr. Coop directly. In brief, the barriers to local authorities becoming more research active could be characterized as both internal and external to the authority, and encompass factors such as contrasting and competing priorities between the local authorities and universities, a lack of understanding about processes for applying for research funding, limited time and resources, and a lack of research systems and policies within local authorities, including processes for ethics and governance. Overall, this work is going to be useful for thinking about and contextualizing what I'm learning about research opportunities with Mornington, and will feed into my recommendations for ways that the authority can become more research active. So my next steps will be to continue collecting testimonies and case studies to inspire and inform, to feed into my final report and recommendations. I'll be speaking to both academics and practitioners, seeking to identify barriers and best practice, and synthesizing case studies that can illustrate examples of successful collaboration. My findings will be reported back to the Borough Council in the form of a senior leadership team report, and we also plan to produce a summary article about the work for a local authority or a practitioner-focused journal or magazine. So that's all I wanted to say today, other than to extend an invitation to the ARC and its members to share any ideas that you may have about building links between local authority practitioners and researchers, or any examples of case studies that you might think might be of interest. My email address is here, and I'm happy to take any questions. Thank you.
Thank you very much, Andrew. I'm just going to check in with Darren about how long we will have for questions. Can we take 3 or 4 minutes, Darren? Literally 3 or 4 minutes. So as stated at the top of our section today, we will take some questions from those of you attending in person. I'm hoping Andrew, Pete and Peter are attending with us remotely. Obviously, Abigail is to my right here. Are there any questions from the floor for any of our presenters today? There is a question there, Ruth, at the back.
Hi, I've got a question for Pete Dixon, and I was just wondering, how does how do you think that ACME is going to impact upon health inequalities?
Cheers, thanks for that question. So we know that these particular conditions are more prevalent in areas of sort of high disadvantage. There's more health conditions needing medical treatment and for longer. So the tool will hopefully encourage doctors and pharmacists to speak to people about them, to understand, you know, whether they would like to change their medicine for one that has less side effects, make them understand that it will hopefully reduce the risk of falls and admissions. And we also know that the people in these areas are perhaps less able or less willing to speak up for themselves. They don't, I know that there's people in sort of better off areas often have better ways of navigating the healthcare system. And so hopefully that if this is in use for GPs everywhere, then it's going to help hopefully make equalize the treatment for everyone and hence make things more equitable.
Thanks very much, Pete. There's a question at the front here, and a question from Dorcas. I'll go with this lady here, there, and that will be our final two questions, as we are conscious of time here in the orange. Yeah.
Yes, sorry, I was going to ask Pete. I mean, you talk about the problems with taking anticholinergic drugs, but people are on them for a reason. So you are looking at reducing the incidence of delirium and falls, but what might you cause an increase in that you ought to be monitoring as well?
Yeah, that's an important, it is an important question. I think I should have done my normal caveat. I mean, you know this, Caroline, but I am not a clinician, so I'm not sure I'm best placed to answer that. But I will feed that back to the group. I'm not directly involved in this either. Unfortunately, Sarah and Ollie, who were unable to speak today. But I think that is an important point. I mean, like I said, when the GPs are given this tool, there's a whole work package involved in this that is around working with the GPs to try and work out how to best deliver that. And that is part of the training, will be a part of thinking, is it clinically appropriate, and are there potential other risks that are you know, related to that switch? But I'm afraid I can't give a direct answer. Did someone say something then, because I couldn't hear it?
You need the microphone, yeah.
Sorry, it's just the big S word, you might increase stroke.
Okay, no, cheers, thank you. I'll feed that back to the team.
Okay, our final question, then we're going to, Dorcas, if you could keep it brief, Dorcas, please.
Yes, it will be very brief, and it's to Peter Lloyd.
Peter Lloyd, okay.
My name is Dorcas, I'm one of the public advisors. Peter, thank you for your presentation, and I know where you are coming from with all the data and how much the public know about data collection and about IMPaCT. How can we empower the patients and the public to challenge the doctors or the researchers where our data are and what's happening to them? Thank you.
Not sure that needs a reply much from me. I mean, I think we just do need a lot more awareness of this. The fact that this news story never appeared in a British newspaper is really rather significant. People should know about this, which is why I took my full pennyworth and shoved it into a meeting of you people. I think you have to spread the word that the ownership of data is important, and that seems to be something that, you know, we need all of us in this business to take on board.
Okay, Dorcas, thank you very much. I'd like to finish by thanking all of our speakers today. A few little hairy moments in there. I think I'll get the job presenting the Eurovision Song Contest when it's in Liverpool next year, dealing with all those things. Thank you all for listening.